I think the hardest point came not long after that diagnosis, and I felt isolated, and I felt alone, and I felt scared, and I thought I was going to die before I could see my son grow. And it was at a meeting, and they asked me, who I was and what my diagnosis was, and I told them, I just want to touch somebody else with Wegener's. And when I did that, 3 people stood up, and they just came and embraced me. And it was the first moment that I went, okay, I can do this. One of the things that was such an important thing to me that day, where those 3 people wrapped their arms around me, was 2 of the people that were there were in remission for several years, and 1 was still actively fighting. And I could look at them and say, okay, I can get there too.
Good afternoon, everyone. Welcome to the latest installment of our Roadmap to Wellness webinar series. I'm Joyce Coleman, the Executive Director of the Vasculitis Foundation, and today is my pleasure to introduce and welcome Dr. Lindsay Lally from the Hospital for Special Surgery to join us. Dr. Lally received her Bachelor of Arts from Princeton University and her medical degree from Weill Cornell Medical College. She completed her residency in internal medicine at New York Presbyterian Hospital and completed her rheumatology fellowship at Hospital for Special Surgery. Dr. Lally specializes in the care of patients with various rheumatic conditions, including vasculitis, systemic lupus, scleroderma, and rheumatoid arthritis. She has a particular interest in the systemic vasculitides. Dr. Lally is actively involved as an investigator in numerous clinical and translational studies focusing on vasculitis. She has been the recipient of several awards, including a VF research grant for her study Rokinase activity in large vessel vasculitis. She is an American College of Rheumatology Distinguished Fellow. During the webinar, we will have all of our participants in the listen-only mode. If you have any questions for Dr. Lally, we will have a Q&A session at the end of her session, and we will try to answer as many questions as possible. Please submit your questions through the chat window. With this, I will welcome Dr. Lally to the webinar and turn my screen over to her.
Okay, thank you. Thank you, Joyce, and thank you very much for everyone who's joining us today. The presentation today is going to be about steroids, a user's guide. I'm sure many, or if not most, or all of the people in the audience today have been on these medications or at least heard of them. And I'm going to try to bridge the gap between the prescribing physician, and I will take note that I prescribe these drugs every day, and the patients who actually have to take these medications. As physicians, we often have a love-hate relationship with steroids, as they work very well, but they also come with a host of side effects. And so the goal of my presentation today...
The broadcast is now starting. All attendees are in listen-only mode.
Hello? Okay. I don't know if I should start again or not. So thank you for joining us. I don't know if you heard my initial talk, but thank you very much. I'm honored to be here today to talk to everyone about Steroids, a user's guide. I'm a rheumatologist who prescribes steroids every day and has a love-hate relationship with these medications, as I'm sure most of the patients and family members who are listening to this presentation do. These are very effective medications, but they also can come with a whole host of side effects. And so the goal of my presentation today is really going to be to discuss certain key side effects that seem to particularly bother patients and try to give clues about how you should be communicating with your physician if you're experiencing these side effects, and what you can do to try to improve or negate some of these side effects on your own. Really a way to kind of empower yourself when you have to take these medications. So without further ado, steroids, as most of you know, are the key component for treatment regimens for basically all forms of systemic vasculitis. So when we have small vessel disease like the ANCA-associated vasculitis, steroids are usually used in combination with other immunosuppressing drugs. And then for some diseases like giant cell or temporal arteritis, steroids are really our first and only treatment, especially up front. And why do we always reach for the steroids? They have very potent anti-inflammatory effects, and they work very, very quickly. So when we are prescribing steroids, we know that the majority of side effects are related to both the dose of the steroids and how long a patient is taking steroids. But unfortunately, we don't know any threshold of really the dose or the time frame for most of the side effects that we're going to discuss today. So it's unfortunate that we can't say if you're on 20 milligrams, you're going to get this side effect, but if you're on 25, you're not going to. Or if you're only on steroids for 2 months, it's okay, but after more than that, you're going to develop side effects. So there's a little bit of an individual relationship between what side effects develop and how long and what dose of steroids patients are on. The type of steroid that we use are also need to be individualized. So we have steroids that can be given by mouth. We have steroids that can be given intravenously. When patients are very sick, if the vasculitis is very severe, often we start out with intravenous dosing of high doses of steroids and then switch to oral formulations. But sometimes vasculitis affects organ systems like the skin, the eyes, the ears, and we can treat those with local steroids, so either steroids in the form of a cream or eye drops or ear drops. And so as physicians, we always try to individualize both how we're giving the steroid, the formulation, as well as the dose and how long patients are going to be on steroids, based on what the individual patient is experiencing and their past experience with steroids and how the disease is active at the time when we're prescribing. Steroids are not liked by a lot of patients, and it is tempting, especially when steroids produce side effects, to just stop them abruptly. But that can be very, very dangerous. And so most of you who have been on steroids know that we often, as physicians, recommend very slow tapering regimens to help avoid steroid withdrawal. And that's really an important takeaway point from this, is that even when you are experiencing side effects, you need to have an open line of communication with your doctor who's giving you the steroids, and you should never stop them abruptly without letting your doctor know. Now, the reason for that is that the steroids we're talking about today are mimics of cortisol, so a steroid that your body makes on its own. The adrenal glands, which sit on top of the kidneys, make cortisol in a regular pattern throughout the day in everyone during periods of stress, and whether that's stress, emotional stress, a physical stress, an illness, a surgery, your body produces more cortisol to help deal with the short-term effects of that stress. Now, when you're taking prednisone or other steroids by mouth, your body's adrenal glands can get a little lazy sometimes, and your body stops making its own cortisol because your body knows that it's getting this by mouth every day in pill form. And so if you stop the steroids by mouth abruptly and don't give your adrenal glands a chance to slowly begin to produce their own cortisol, you could have signs of steroid withdrawal or what we call adrenal insufficiency, which usually people get very tired, feel just crummy, achy, very weak, or what we can call an adrenal crisis, which is an extreme version which can be life-threatening, where patients have dangerously low blood pressure and can have all sorts of electrolyte and blood imbalances. Now, that's very rare, but that's what, as physicians, we're always trying to avoid when we tell people to slowly taper the steroids. And during certain periods of stress, when you've been on steroids for a while, and whether that stress is a severe illness or a surgery you need to undergo, it's very important that all of your doctors know you've been on steroids for a while, because sometimes to give your body the extra boost during those periods of stress, when you've been on steroids for a long time, you need a little bit of extra steroid to mimic what your body would do in terms of cortisol production. And we call these stress dose steroids. So again, it's just important that all your physicians, not just the doctor treating your vasculitis, knows what dose of steroids you're on and how long you've been on those steroids. And just as an aside, the steroids we're talking about today, again, are these corticosteroids mimicking cortisol in your body, not the steroids that we see in the newspaper. And this might be more specific to me. I'm in New York, but not these performance-enhancing steroid medications that our athletes take or don't take to improve their performance athletically. And so these are not what we're talking about today, but sometimes patients get confused. When I'm talking about steroids, and we're going to go through now a lot of the side effects that patients are particularly disturbed by or bothered by when they're on steroids. And my goal isn't to just give you a whole laundry list, but the point of this slide is to show that steroids can really affect every organ system in the body. And again, some of this can happen quite quickly or from only taking steroids for a few days, but the majority of these side effects happen over time with prolonged use of steroids. And this is really why we often reach for steroids up front. They work quickly and they work very well, but then we try to get patients off steroids and avoid the long-term side effects of being on steroids. In the skin, we know that steroids pretty quickly can cause changes in the skin and thinning in the skin. This can also lead to increased bruising. When patients need surgery and they're on steroids, their wounds might take a longer time to heal because of these changes in the skin. And certain areas of stretch marks, also called striae, on the back and abdomen are also more noticeable when patients are on steroids because of the changes in the thickness of the skin that we see. From the ophthalmologic point of view, the eyes can be very affected by steroids. Patients can develop cataracts, and they can also develop glaucoma. So it's important that if you have eye problems to begin with, when you're on steroids, your eye doctor knows that you're on these medications, and you follow with your eye doctor regularly to make sure none of these problems are developing. Steroids in the short term can also cause differences in how your body can handle fluid, can lead to holding on to too much salt and fluid, which can raise the blood pressure. Some people get a lot of problems with heart rhythm when they're on steroids. It can cause palpitations, heart racing, skipping a beat, and it can also change the way that your cholesterol looks. One of the things we're often concerned about when patients are on steroids is irritation to the stomach lining, which can even lead to ulcerations and bleeding from the stomach and the intestines. Now, when patients are on high doses of steroids or have had problems with their gastrointestinal system in the past with things like ulcers, oftentimes we give them a medication to take with the steroids to protect the stomach lining and avoid this irritation or ulceration of the gastrointestinal tract. Something I'm not going to focus on a lot today, but that is a very important consequence of steroids, can be changes in blood sugar and even the development of diabetes. So diabetes occurs when the blood sugar is too high, and steroids can cause what we call hyperglycemia or high blood sugar that can develop into overt diabetes, especially in patients who might be pre-diabetic at the time when they start the steroids. So this is something that we watch out for very carefully, and in terms of signs or symptoms of diabetes that patients should be aware of, when you have excessive thirst, excessive urination, and sometimes accompanied by weight loss, that can be a sign that you might have early onset of some high blood sugars or diabetes and should make your doctor aware of that. Patients can also have menstrual irregularities when they're on steroids, and something we'll talk about in a little bit. Weight gain is also a big issue when patients are taking corticosteroids. We'll talk some more about how steroids can affect the bone and muscle and the one's mood later in this presentation. So one of the major things we are concerned about when patients are given steroids is the development of infection. This is similar to most of the medications we use to treat the different forms of vasculitis, because we know that we're suppressing the immune system when we're giving patients these medications. So why does steroids make patients more prone to infection? Certain types of immune cells are being suppressed. Now, this is partly intentional to treat the underlying vasculitis, but it does make patients more at risk for various types of infections, including bacterial infections, viral infections, and even certain fungal infections. And it's not just the medication themselves that make patients more at risk. There are certain individual factors, such as one's age, the underlying diagnosis, and comorbidities such as diabetes or cancer that can make people more likely to develop infection while they're on steroids. Similarly, if you're on other medications for your vasculitis that suppress the immune system, things like cyclophosphamide, rituximab, methotrexate, those can all make you more likely to get an infection when you're on higher doses of steroids. So what can you do as a patient taking steroids to try to avoid these infectious complications? So firstly, most doctors will screen you for certain infections before they even give you the steroids. And these include things like tuberculosis and hepatitis, which we know on high doses of steroids can become active if you've been exposed in the past. So screening before you start can help prevent development or reactivation of those infections. Sometimes we also give prophylactic medications to prevent certain infections if you're going to be on steroids for a long period of time. So this is particularly relevant for patients who have ANCA-associated vasculitis, and we know they're at higher risk for development of certain types of lung infections or pneumonias called PCP pneumonia, and sometimes we give a medication called Bactrim to prevent this infection from developing. If patients have had a history of shingles, sometimes we also give an antiviral medication if we know they're going to be on high doses of steroids for a long period of time to prevent reactivation of the shingles virus and coming down with that infection again. Vaccinations are also very important for all patients who are on immunosuppressive medications like steroids. These include routine influenza vaccinations every year and the pneumonia vaccination. But it is important to know that live vaccines are contraindicated when you're on high doses of steroids or other immunosuppressing medications. So the live vaccines that are most relevant in this population include the shingles vaccine and the intranasal flu vaccine. Both of those would not be safe when you're on high doses of steroids, and so again, this is an individual conversation that you should have with your doctor, and it's best when your physician is thinking about these things before you even start on the steroids. Again, now communication with your doctor is also key when you're on steroids, and so if you start to feel like you're coming down with an infection, and whether that's a fever, a cough where you're bringing up a lot of mucus, an area of redness and pain on your skin, anything that seems to you out of the ordinary and that could indicate an infection, it's important to talk to your doctor about these things and let them try to work up if they think this is an infection. This can be difficult sometimes because sometimes the signs of infection are very, very similar to the signs of vasculitis itself, and so it might take a little working out on the part of your doctor and you working with your doctor to determine if this is really a new infection or if this is the vasculitis becoming active again. And obviously, if you have an infection, you might need to come down on some of the steroids, and if this is the vasculitis being active, your steroid dose might need to increase. So it's a very important distinction that needs to be made. And then lastly, in terms of just common sense, is, how do you avoid infections? Everything that, you learned in preschool, wash your hands. If someone's sick and sneezing and coughing, you stay away from them. Remember that these medications do make you immunosuppressed, or your immune system is not as strong as others, and so you should proceed with caution, especially during cold and flu season. Another major issue with steroids, and probably the complaint that I hear most often in my office about from patients when they're on steroids, is that they gain weight. And why do steroids cause weight gain? For many reasons. One, and for reasons that we don't understand so clearly, is that steroids cause an increased appetite. So part of this is sometimes when there's a lot of inflammation going on from the vasculitis, people don't feel well, they're not eating that much because they just feel so crummy, and then once they get on the steroids, they start feeling better, the inflammation is better controlled, and they feel more like eating. But the steroids go above and beyond that and increase the appetite on top of what one's normal appetite usually is. So people are eating more, they're hungrier. They're also sometimes holding on to more fluid, which can lead to swelling, particularly in the legs, and an increase in water weight. Sometimes there's decrease in physical activity, and the steroids also can cause a change in the way that your body stores fat. And so you get a redistribution of fat, particularly in the face, in the belly, and on the back. On the back, you get what is referred to sometimes as a buffalo hump, which can be kind of a collection of fat on your back, as well as, patients often complain that their pants are getting too tight, they're gaining weight in their abdomen. And then we have that classic, what we call a Cushingoid appearance, or the moon face, where the face gets more full and round after being on moderate to high doses of steroids for a prolonged period of time. All of these things are reversible, but all of these things are understandably quite distressing to patients when they're experiencing them. So as a patient who has to take these medications, what can you do? So there are several steps you can take. First, as we talked about, sometimes some of the weight gain is related to holding on to fluid and too much salt. So if you limit your sodium intake, you can help alleviate some of those problems. And just remember that the high sodium foods include canned foods, processed, and frozen foods. And so a diet based in more fresh fruit and vegetables, low-fat dairy and protein, and particularly if you're preparing meals at home, that can all be helpful to make you limit the amount of sodium that you're taking in your diet, which can help with how much fluid you're holding on to. It's also important to just be mindful of what you're eating and how much you're eating. There's the concept of empty calories, so especially if you know that the steroids are going to make your appetite be increased, you might want to make sure you're eating small meals, healthful meals, high in protein, to help with a little bit of fat, and those healthy fats like those omega-3 fats that you find in nuts and certain produce like avocados that can help you stay full longer, and may help you curb your appetite, and that if you're eating, you are eating good calories and not so much empty calories. This can all be a little overwhelming, especially when you're in the midst of dealing with your vasculitis and how that's affecting other organ systems and other parts of the body, and figuring out what you should be eating and what you should be avoiding can be difficult. And so most vasculitis centers and doctors should be able to refer you to a nutritionist who understands these medications, understands what effects steroids have on the body in terms of weight gain, and can help you make an individualized plan that will hopefully help curb some of the weight gain that we would see when you're on steroids. So don't be afraid to ask your doctor about sending you to a nutritionist for a consultation. And lastly, exercise can be very, very important to help combat the weight gain. And it doesn't have to be running a marathon or spending hours and hours at the gym, but a daily exercise regimen based on your fitness level and making sure it's safe based on the status of your disease can be extremely helpful in combating some of the weight gain that we see when patients are on steroids. And I'm going to talk about exercise a few more times during this presentation, but it's important to note that you should always speak to your doctor first before you start any new exercise regimen, and make sure they think that whatever you're going to be doing is safe for your medical status. Another thing, side effect that we worry about when we give patients steroids are the effects on the bones. Steroids can pretty quickly lead to thinning of the bones, which is called osteopenia, or osteoporosis. And why we're concerned about thinning of the bones is that it can lead to fractures. We know that steroids work on the cells that regulate the bone in the body, and they both decrease the activity of cells that build bone up, and they increase the activity of cells that break bone down. So the overall effect is a decrease in the bone density, or a thinning of the bones. And again, this happens preferentially from steroids in the spine. And so what we really worry about are these things called compression fractures. You can see in this picture, you kind of have where this arrow is pointing, this wedge-shaped defect in the vertebrae in the spine. And that corresponds to a fracture. Now, compression fractures usually are diagnosed when patients come in with acute onset of back pain. And this isn't usually from a lot of trauma. So it's what we call a fragility fracture. The bones are thin, and little to no activity can cause these fractures. So stepping off the curb, twisting one way or another, and suddenly a patient has severe mid-back pain. That's something that if you're on steroids and you experience, you should let your doctor know right away. And usually it's apparent on a plain x-ray, though sometimes in the very early stages, a different sort of imaging like an MRI might be necessary to make this diagnosis. But it's important to diagnose this quickly in order to help prevent A, further fractures, and B, to manage the pain that you're experiencing, because these things tend to be very painful in the initial setting. And what can you do when you're having, if you have osteoporosis related to steroids? So most of the time we like to know where we're starting. So before we prescribe steroids or at the beginning of the treatment, your doctor will probably ask you to get a bone density or DEXA test. That way we know what the bone density is at the beginning of steroid treatment. The building blocks of bone include calcium and vitamin D, and in the vast majority of patients on steroids for a prolonged period of time, your doctor will recommend that you take extra supplementation in the form of calcium and vitamin D. These doses that I list here are ranges, but your doctor can individualize the dose. Sometimes, depending on how thin the bones are, your doctor might prescribe extra medication to prevent bone loss. These include medications like bisphosphonates. Some examples are Fosamax, Boniva, or other medications that are given intravenously or subcutaneously to help minimize or even help build bone. Weight-bearing exercise can be particularly helpful in terms of helping to build bone and reduce bone loss. So again, these are resistance exercises, exercises using light weights. They can do a lot to help you prevent further bone loss. You should check with your doctor before you start such a regimen, but it is something that can help counteract the effects of steroids. The bones can improve in their bone density after steroids are discontinued. So remember, this isn't something that necessarily has to be a permanent thing, but especially if you're going to be on steroids for a long period of time, it is something that you should be aware of and that your doctor should discuss with you. And like I said before, really one of the things we're most concerned about is the development of fractures. And if you have this sudden onset of back pain, it could be that you had a fracture in the spine, and you should let your doctor know right away. Another problem that many patients experience on steroids are what I'm going to call neurocognitive disturbances, but basically changes in mood, and changes in mood can be increased anxiety, increased depression, mania or hyperactivity, poor sleep, and even frank psychosis. So there's a broad range of symptoms that I'm including in this category, and we don't really understand why steroids have this effect on patients. We know that it's more common at higher doses, that people who have been on steroids in the past and had a lot of problems with their mood may be more likely to have problems with their mood if they go on steroids again. And again, these cognitive effects really vary between individuals. So it can, run the whole gamut from depression to mania. So some people can get very down. Some people can get extra amped up. People can be very jittery, and everything in between. One of the biggest complaints that patients have while they're on steroids is insomnia or trouble sleeping. This is a big problem for patients and doctors. We recommend that if your doctor is having you take steroids in a divided dose, that you take your second dose of the day early in the evening or in the mid-afternoon, not right before bedtime, to try to optimize how much sleep you can get. But sometimes sleep aids may be necessary, ranging from over-the-counter sleeping medications to prescription sleeping medications. You should always talk to your doctor before you start any over-the-counter or new prescription to help you sleep, just to make sure it's safe with all of the other medications and medical problems that you may be experiencing. Again, depression and anxiety are a big problem in patients who are on steroids, particularly patients who have had maybe some issues with depression and anxiety before they went on steroids. The effect of steroids can really heighten those mood symptoms. So we know that regular exercise, again, can be very, very beneficial. And so it's important to talk to your doctor first, but make yourself a exercise regimen that you can stick with that can help not only some of these other steroid side effects like the weight gain, but can help with some of the neurocognitive disturbances you're experiencing too. And if you feel like you need more support, you're not safe at home, you need counseling, you should feel free to talk to your doctor and tell them that, you know, you're concerned and ask for a counseling or a mental health referral. On the opposite side of the spectrum, people can have mania with steroids. They, you know, tell me that they've been up all night since they started the prednisone and cleaned out every closet in their house, and you know, they can feel like they have excess energy, but this isn't good either. And these people often need medications to help them sleep or to help them balance their mood. Especially, there is an entity called steroid-induced psychosis that we see when people are on very high doses of steroid, and people can be delusional and having hallucinations, and it can be a very scary thing for patients and physicians when someone's going through this. And if we know that someone's been through this in the past, often, and if they're going to need more steroids, then we treat them again before they start the steroids with a mood stabilizing medication to ensure that we don't run into these problems again. Another problem that patients can develop on steroids that is often or under-recognized is myopathy or muscle weakness. And this occurs because steroids can have a direct effect on the skeletal muscle. They change the way that muscles use glucose and kind of are active, and they can increase the breakdown of muscles. Usually what we see is a very kind of slow onset of muscle weakness. People might not even actually realize it's happening. It's usually in the quads and the deltoids and the neck muscles, the muscles closer to your trunk that become weak first. And patients might notice that standing up from a chair or getting up from the toilet, climbing stairs, doing overhead activities like brushing their hair or putting dishes away in a high cupboard might become just more difficult because the muscles just feel weak. And again, there's not a great blood test to diagnose this always, and your doctor might be able to detect it on physical exam, but it's something to be aware of because this is something that also can be very impairing to patients and can be treated. We also know that patients who have a sedentary lifestyle or are inactive are at increased risk to develop this side effect because the inactivity in the muscles may make them more sensitive to these effects of the steroids and the steroids breaking them down. So what can you do to avoid this is maintain your activity and have a low level of exercise to prevent this from happening. And if this does happen and you do develop muscle weakness, then exercise and resistance training can work to improve your strength. Sometimes if the weakness is very profound or limiting, physical therapy evaluation to focus directly on strengthening exercises for the involved muscles can be helpful. There's also some evidence that different types of steroids might be more or less likely to cause these problems, and so you should talk to your doctor about that as well if you feel like you're developing this muscle weakness. And prednisone, which is the most common steroid used to treat vasculitis in this country, does seem to have a lower risk than other formulations of steroids in terms of predisposing people to develop this muscle weakness. We know that this is not a permanent condition, and that strength will improve several weeks after the dose is reduced of the steroids, and eventually it will resolve when you're off of the steroids. So you will get back to your baseline strength, but this can take time, especially in the setting of systemic vasculitis when there's been a lot of illness and systemic inflammation. So in terms of looking forward, steroids are an old medicine, and like we've talked about, they're a medicine that are used very, very frequently. But as physicians and researchers, especially in the vasculitis community, we're really looking forward to a day when we can treat patients with either a very low dose or no steroids. And how we're trying to get there, there are some newer formulations of steroids that might be able to allow for a smaller dose initially to treat patients. And we're trying to figure out if we can have regimens that start with lower doses or taper the steroids off faster so patients aren't on steroids for as long a period of time. These are all areas of active research. And we do have a lot of research studies going on in all different forms of vasculitis, where the goal is really to find either alternative medications to steroids or to find if we can safely give patients lower doses of steroids, or if we can safely get patients off steroids quicker. And after I finish my presentation, you'll hear about one of those exciting studies that is going on currently for patients with granulomatosis with polyangiitis, or GPA. So in conclusion, as of now, steroids are here to stay. They're a very important and effective part of vasculitis treatment, and so most patients who are diagnosed with vasculitis are going to end up on steroids at some point. How we can do this safely and effectively is by partnering with your doctor, so you can feel free to discuss your concerns and side effects if and when they develop. And one of the themes I'm sure you've noticed during this talk is that moderate, regular exercise can really do a world of difference to reduce or relieve many of the common side effects that are most concerning to patients while they're on steroids. And so if your doctor says that that's safe, it's really something important to consider. So with that, I'm going to end here, and happy to take any questions.
Great. Dr. Lally, thank you so much for this information. We have a few questions. Ryan submitted a question. What is considered a high, or no, Jane did. What is considered a high dose of prednisone?
Yeah, so that's a very good question, and it's a little bit of semantics. We usually consider doses over 20 milligrams to be moderate, and then doses of around 60 milligrams to be high-dose steroids. And again, sometimes depending on what the disease and the manifestations are, patients need even higher doses than that, and that we usually give intravenously for a few days.
Great, thank you. Another question is about how prednisone, can it affect your hair? And I know you mentioned that in one of your first slides. Does prednisone affect hair? And can you get your hair thins or you lose it, can you get it back?
Yeah, so prednisone can definitely affect the hair. It sounds like your experience, it can make your hair thin on your head, and it can actually sometimes cause people to grow hair in places that they don't want hair. Particularly, it can, in some women, lead to some facial hair growth. These are all things that when you're on lower doses or no doses of prednisone will be reversed. So any hair thinning you experience because of the medication will be reversed when you're off of the medication, and hair growth that you experience in unwanted places while you're on the medication will also get better once you're off the medication.
That's always good to know. Another question, thank you. Another question is, are there more special considerations for ongoing prednisone use for teenagers?
You know, I'm not a pediatric rheumatologist, so I don't know. I might not be up to date in the latest concerns about teenagers, but there is, you know, certain concerns about prednisone use and steroid use in children and adolescents because it can have effects on growth and particularly bone growth. That being said, a lot of the doses of medications that I've mentioned today are particular to adults. Children metabolize steroids quite differently, as they do for a lot of medications, and so they often require actually higher doses of these medications on a by weight basis than adults do. So I don't know of any particular new research about prednisone use in teenagers, but growth is always a concern with long-term use of these medications in kids.
Okay, great. Another question is, how does prednisone affect cholesterol?
So prednisone and other types of steroids can kind of falsely or temporarily elevate your cholesterol profile, especially the triglycerides. So high levels of triglycerides are often seen when we're checking the blood of patients who are on high doses of steroids. This again is something that will be reversed when you're back off of these medications or on lower doses. And if cholesterol is a concern and you're on steroids, you should be following a low cholesterol diet, and you should make sure that when you're getting the cholesterol levels checked, you're doing so when you've been fasting.
Okay,
To
great.
get the most accurate level.
Okay. What is your opinion about reclassed to build bone in someone with osteopenia?
Yeah, so reclast is one of those bisphosphonate medications that work well to help prevent further bone loss when you have thinning of the bones, osteopenia or osteoporosis. Reclast is given intravenously as opposed to some of the other medications in the class, which are oral. And, you know, dependent on your individual bone density and your history of fractures, it can be a very, very effective medication to help prevent further bone loss that could be induced by being on steroids.
Okay, thank you. Another question, how much of the steroids in the Advair inhaler, does that affect your bones?
So most of the, and that's a good point, I didn't mention when I was talking about different formulations of steroids, I did not mention inhalers, but inhaled steroids, the majority of them go right to the lungs where they're needed, and very, very little is absorbed systemically. So I would not really consider, even though sometimes in the side effects you can see that they give warnings about bones and eye problems with inhaled steroids, it's really not something that we see because of the very, very minimal levels that are absorbed systemically. So I wouldn't be overly concerned about the effects on bone if you need the inhaled steroids for something like asthma.
Okay, thank you. Do you have an opinion about Evista for bone loss? Is that along with Reclast or something separate?
Evista is it's a different type of medication. It's actually a hormone medication. Evista can be good at preventing bone loss. The issues with Evista that one would want to talk about with their doctor, there is a higher rate of blood clots in people who are taking a Vista, and we know from some other research that patients with certain types of vasculitis might be at higher risk to develop blood clots from their disease itself. And so that would be something that I would just want to make sure I'd fully discussed with the prescribing physician before before recommending a Vista for someone with vasculitis.
Okay. Brenda sent in an email. Her question is, what about the use of CoQ10 with prednisone tapering?
You know, there's not a, so CoQ10 is a supplement, and you know, there's not a lot of data to support any of these antioxidant or other supplement uses to that they can help with getting off steroids faster. So I don't really have much more I can say about that.
Okay. Okay. Deborah submitted a question. She's been on, and this is pretty specific, so if you want to make it more general, she's been on 5 milligrams of prednisone for the last 4 years, and every time she goes off, if she gets down to even 4.5, she gets the withdrawal symptoms, the body aches, the feeling of her body shaking inside out, just feeling terrible. Do you have any thoughts on, is there something, is it just that her adrenal glands have shut down completely, or is there any way to jumpstart them? That's her question. Is there a way to jumpstart the adrenal glands?
Yeah, so this is a common problem. A lot of times patients get down to low doses of prednisone, but then, we can't quite get them off. As doctors, we have a couple of tricks that we try sometimes. We try to reduce the dose every other day, so you take 5 milligrams one day, 4.5 the other, or go down very, very slowly in half-milligram increments. It's not unusual, though, that after being on low doses for a long period of time, you do feel those withdrawal symptoms. Now, usually, those will go away within 3 to 4 days, and so sometimes kind of just sticking through the uncomfortable feeling can kind of give your body time to start making their own making its own cortisol, and then after that you are able to go down further. But as we'll hear from Joyce, I think you're going to talk about it in a little bit. There's a topic of active research and kind of debate in the vasculitis community right now is, is it okay and safe for people to be on a little bit of steroid for a while, around that 5 milligram range, or is the goal in everyone really 0 milligrams? And that's something that different doctors have different opinions about, and something that we're trying to, use the resources in our patient population to actually get a more definitive answer for.
Right. So I think that's a great segue into the next part of the webinar. So the last question for you, though, Dr. Lally, it just popped in from Twitter. What are the best practices for exercise if you're experiencing fatigue and pain?
So, everything is individualized, and it is hard. It's easy for me to sit here and, talk about that everyone should be exercising, but I certainly understand that when you're dealing with a disease like vasculitis and you have a lot of fatigue and joint pain or muscle pain, it's not that easy. The best practices are to go slow, and slow and steady can really still make a world of difference. And whether that's, building yourself up to walk around the block once and then walk around the block twice, is good. If you have a flight of stairs that you can walk up once a day, something like that, to keep the muscles in your legs active. Really, it's very individualized, and sometimes that's where the physical therapist can be helpful, asking for a referral to physical therapy, because they can really work with you on an individual level and help you tailor a program that you can be doing at home to exactly kind of where your pain is and what you're capable of doing at this point in time.
Great. Well, thank you again so much, Dr. Lally, for joining us today and sharing your information and your expertise and knowledge. We are greatly appreciative of it. Can you make me a presenter and I'll move on to the taper? Thank you, Dr. Lally, for sharing your expertise and knowledge today. I would like to turn our attention to the taper trial. Today, Dr. Lally has discussed many of the pros and cons and other considerations for use of prednisone therapy for vasculitis. However, there is still much that we have to learn about prednisone use and considerable practice pattern variation in what physicians recommend and prescribe to their patients in remission. One study that is looking at some of these issues is the Assessment of Prednisone in Remission, or TAPER trial. This study is funded by the NIH and is sponsored by the Vasculitis Clinical Research Consortium, the VCRC. The TAPER trial is investigating whether patients with granulomatosis with polyangiitis, also known as GPA Wegener's granulomatosis, are better off being maintained on low-dose prednisone 5 milligrams per day or attempting to come off of prednisone altogether when they are in disease remission. Some experts support the use of long-term low-dose prednisone, claiming improved disease control, a subsequent reduction in the exposure to toxic immunosuppressive medications, fewer periods of exposure to high-dose steroids, and a reduction in the accumulation of disease-related scarring. Other physicians argue that the use of long-term low-dose prednisone is ineffective at reducing relapses and exposes patients to the potential toxicity of high cumulative doses of steroids, but there is limited clinical data to support one approach over the other. The TAPER trial is also looking at trying out a new model of clinical research that is patient-focused. In the TAPER trial, patients can join the study and complete all of the study forms and surveys online from their home or while they are on the go, so no travel to a research clinical center is required. While patients are enrolled in the TAPER trial, they will remain under the care of their own doctor, so they don't have to switch doctors or see a new doctor to participate in the study. Thus, there is a better continuity of care. The TAPER study is a randomized, controlled clinical trial, so patients will be randomly assigned to either stay on 5 milligrams per day of prednisone or come off of prednisone altogether. The study is unblinded, meaning that both you and your doctor will know what prednisone dose you are taking throughout the study. So who is eligible for the TAPER trial? Patients must have a diagnosis of granulomatosis with polyangiitis. Their GPA must be in disease remission at time of enrollment. Patients must have had an active disease within the prior 12 months, meaning initial presentation or relapse, that required treatment with prednisone of greater than 20 milligrams per day. The prednisone dose at time of enrollment is between 5 and 20 milligrams per day. Please note that participants may be on other medications for the control of their GPA disease besides prednisone and still participate in this trial. Patients must be age of 18 years or greater, and a patient's doctor must be located in the U.S. Also, a patient's doctor must agree that participation in the study is appropriate for his or her patient. The only exclusion criteria is that patients should not have any other health conditions that may require them to have treatment with oral or IV steroid treatment. For example, COPD, asthma, etc. Patients may take inhaled steroids for asthma or other conditions. This slide shows you an overview of the TAPER study timeline if patients choose to enroll. On 1, patients with GPA are recruited online to visit the study website, tapertrial.org, and learn more about the study. 2, patients will agree to participate online in the study and then enroll by answering a few questions about themselves and their disease. 3, patients will then receive a form that we call a physician packet that patients should send to their doctor that treats their vasculitis. This form will also be mailed to the patient with prepaid postage, so there is no need for an in-person visit with your doctor. 4. In order for the participant to be eligible for the study, their doctor will need to agree that participation in the study is appropriate for the patient. Once the patient's doctor signs the physician packet form, they will send this back to the taper study team. The taper study team will let the patient know once the form has been received, and the patient will begin tapering their prednisone dose down to 5 milligrams per day. 5. Once the participant reaches 5 milligrams per day, they will be assigned to either stay on 5 milligrams per day or continue to taper their prednisone dose down to 0 milligrams per day. This study is randomized, so the chance of a patient being assigned to either the 5 milligrams or 0 milligrams study treatment group is random and like flipping a coin. Patients will continue to enter their prednisone dose online on the study website and tell us how they are feeling. All forms for the study will be completed online by the patient themselves. Participants will be followed for 6 months in the study. Patients will stay on the study dose for the full 6 months unless the patient's doctor tells them otherwise. Remember that a patient will remain under the care of their own doctor throughout the study, so your doctor can change your dose if they feel it is clinically necessary. To find out more about the TAPER trial, please visit the TAPER trial website at tapertrial.org or email the TAPER team at taper@epi.usf.edu. You can also follow us on Facebook, on Twitter, and on Google. Thank you all for attending today's webinar. We hope you found it interesting and informative. Our next webinar will be held on Thursday, April 23rd, 2015 at 1:00 p.m. Central. Our speaker will be Dr. James A. Garrity, and he will be speaking on eye involvement in vasculitis. Dr. Garrity is a longtime member of the VF Medical Consultants and Scientific Advisory Board. He is a professor of ophthalmology at the Mayo Medical School in Rochester, Minnesota. He is the author or co-author of more than 100 publications and is also a scientific reviewer for several peer-reviewed journals. Dr. Garrity's clinical practice and research interests include vasculitis, Graves' disease, and orbital diseases. We hope you will join us for this interesting and informative webinar. During Vasculitis Awareness Month in May, our webinar will feature Celeste Lee, and she will be speaking on living well with vasculitis. The webinar will be held on Wednesday, May 13, 2015, from 12 to 1 p.m. Eastern Time. Ms. Lee is a program manager for the Patient and Family-Centered Care at the University of Michigan Health System. She has extensive experience in patient and family-centered care initiatives and brings a unique outlook as both a patient advisor and as a patient with end-stage renal disease. Ms. Lee has had GPA for over 31 years. She is committed to improving quality of care and quality of life those with end-stage renal disease, and she serves on several state and national patient advocacy boards. We hope you will be able to join us for one of the webinars, and we also want to remind you that all of the webinars are recorded and can be found in our archive library on our website. I would also like to invite you to attend the 2015 International Vasculitis Symposium to be held June 19th through the 21st in Jacksonville, Florida. The International Symposium is held every other year and will feature many of our vasculitis experts. We invite our patients, family members, and their physicians and friends to attend the symposium to learn the most current information on treatments, research updates, and also to have a chance to network and meet other patients and family members. The symposium will start on Friday afternoon at noon and end on Sunday about noon. We hope you will join us. More information can be found on the VF website at www.vasculitisfoundation.org. Thank you again for joining us for today's webinar, and we look forward to seeing you at a future one. Thank you. Have a great day.